Good evening, everyone, and thank you so much for joining us. My name is Annie Benzie. I am the chair of the SSAT Convex GI Surgery Fellows Subcommittee in charge of organizing this Grand Round series, and we have a great talk set up for you today. Just give you a couple more minutes to get settled. And it is really just my honor and a privilege to introduce our moderator, Dr. Vahag Nagolian. He's assistant professor of surgery, an extremely accomplished abdominal wall reconstructive surgeon that I actually watch videos of before my big cases. I've learned a lot from him, and I'm really excited for him to be our moderator this evening. And also, he's from Oregon Health and Science University. Excuse me, I forgot that part. Got a little overwhelmed. And I would just like to introduce him and have him kick us off, and then introduce our fellow for this evening from Atrium Health.
Hi, everyone, and thank you so much for that very nice introduction. It really is my honor to be here facilitating a conversation with John Ewing. Dr. Ewing is a fellow currently at the Carolinas Atrium Health, working alongside some of the most prominent hernia surgeons in the world at one of our true crown jewel hernia centers in the United States, and really excited to talk about the very broad topic of abdominal wall surgery. John, I think we have a lot to cover over the next hour, and I know that you'll have the capabilities to get it done. So why don't we go ahead and get started? As we sort of go through this presentation, I want everyone to know that there's going to be a lot of opportunities for built-in discussion. We basically have three phases of the presentation. We've built in some discussion slides to clarify, ask questions. We'll be trying to keep account of the chat box. So if you have specific questions, please feel free to send them out through the chat. I'll try to intermittently answer, and if there are opportunities to really take it to the next level with active discussion, we'll definitely introduce those questions during the discussion phase of the presentation. So with that said, why don't we get started, John? The floor is yours.
Perfect. Well, thank you so much, Dr. Benzie and Dr. Nagolian. I really appreciate the opportunity to talk today, and look forward to having a conversation with everyone in attendance. I'll first off say that a lot of the data that I'm presenting, I feel like I'm really presenting the work of my mentors and fellows and other trainees who've come before me. So I really appreciate the mentorship that I've had in fellowship from Drs. Henneford, Colavita, Kircher, and Dr. Augenstein, and all of those who've contributed to this kind of body of research from our institution and elsewhere. So I'll start by kind of giving an overview of what we'll aim to talk about today. I really want to go through kind of the key phases of the care of an abdominal wall patient. And so we'll start by talking about pre-optimization and talk a little bit about the data behind some of the core tenets of that: smoking cessation, diabetes control, and weight loss. I'll also talk about a couple other aspects that have proved important, penicillin allergy and how we address that in our abdominal wall in other general surgical patients, lateral abdominal wall chemoderivation as well. We'll review some of the operative techniques that are important for ventral hernia repair. This is not meant to be exhaustive, but we'll talk about ventral hernia repair concomitant with paniculectomy. We'll talk about the benefits of negative pressure incisional wound therapy. We'll talk about preperitoneal mesh placement and our approach to component separation. And then we'll also discuss postoperative care or perioperative care with some ERAS tenants, and in particular, liposomal bupivacaine tap blocks. So kind of weaving through this, I'll use a patient as a template. This patient is a 58-year-old gentleman who presented with a large abdominal wall hernia. When we first met him, he had actually lost 70 pounds, but he still had a BMI of 51. He had increasing abdominal wall bulge with discomfort. It was pulling with movement. He had a job where he was, physically active frequently, and this was causing some real difficulties for him. He was constipated but not obstructed. His medical comorbidities were notable for type 2 diabetes, among the others you see listed there. And really his only surgical history was an open Roux-en-Y gastric bypass, a little bit of a throwback that was in the very early 2000s. He was on on medications for hypertension, and he was also on semaglutide. He had a remote history of a penicillin allergy with a rash. He was a non-smoker. And so here you see some representative slices of this gentleman's CT scan. He had a large defect, 22 centimeters by 17 dimension. He had nearly 70% of his small bowel in the hernia sac that extended down into his pannus, as you can see on the sagittal section here, his hernia filling that pannus. And so talking initially about pre-optimization there, this is really our opportunity to address any modifiable preoperative risk factors with a patient. And so while we think about weight loss and smoking cessation, really if a patient has a particular pulmonary comorbidity, cardiac comorbidity, this is our opportunity to engage subspecialists and make sure those risks are mitigated before these patients undergo a major operation. Our practice is smoking cessation 4 weeks prior to an elective hernia repair, oftentimes with negative urine cotinine. We require weight loss for patients with a BMI greater than 35 to 40, and our diabetes control target is an A1C less than 7.2%. We discussed penicillin allergy preoperatively. And also, in the last several years, we've incorporated geriatrics assessments into our clinic with a geriatrician seeing patients selectively who are greater than 65 and very frequently those who are in their high 70s, particularly if they have geriatric-related medical comorbidities. We've viewed this as a really important opportunity to address polypharmacy, frailty, and risk factors for post-acute care needs in the preoperative setting. So looking first at obesity, I think this is a tough, we know that obesity puts patients at higher risk of skin necrosis, recurrence of hernia, of wound complications. Desai and colleagues have described this in 2016 for anyone with a BMI greater than 30 in abdominal wall reconstruction. Our data at Carolinas has demonstrated a 1.08x increase in wound complications for every point above 26. And then expert consensus of abdominal wall surgeons based on meta-analyses have really kind of honed in that there is certainly a gray zone. The patients with a BMI greater than 30 have an associated increased risk of wound and perioperative complications, and those greater than 50 should probably not undergo an elective repair. And really in that window, pre-optimization is the key. Really, though, this ends up being a patient-specific discussion, and there are a lot of factors that can go into this. If a patient's had multiple hospitalizations for bowel obstructions related to their hernia, or if they have a hernia morphology of a narrow neck and a very angulated hernia sac that predisposes them to obstructions, that patient may have not have as aggressive of a BMI target. Similarly, a patient with a smaller, with less visceral adiposity or a smaller defect may, weight loss may not be quite as aggressive or as intense as it would be for someone with a very large defect, visceral adiposity, and a large volume of extra abdominal contents. So one thing that comes up with this that I think is an interesting thing our group is looking into is, and I give all the credit here to Dr. Holland, she's one of our excellent lab residents, is the work we do for preoperative waist loss for hernia patients, is this durable? So she queried our patients over the last 10 years who had made it to ventral hernia repair. She looked at those who initially presented with a BMI of greater than 25 and who had greater than 10 pounds of weight loss prior to surgery, and compared their initial consult weight, their preoperative weight, their weight at 6 to 1 years post-op, and then their most recently documented weight. And she found that on average, the weight loss was about 26%, 26 pounds, and the patient's BMI decreased from about 38 to 34 preoperatively. At their 6 month, 1 year visit, which ended up being about 8 months on average, patients averaged an additional 1.8 pounds than their preoperative weight. And then looking at the long-term data, which I think is the real important time point here, for which the average follow-up time was 42 months, the average weight change was actually a gain of 2 pounds relative to the preoperative weight, so right before surgery. So the average net weight loss was 24 pounds. And looking at separating this into different groups, we saw that 83% of patients maintained a lower weight than their initial consult, with 47% of patients who continued to lose weight after surgery, and only about 17% regained all their pre-op weight loss. So I think this data is really encouraging for abdominal wall surgeons in that the pre-optimization efforts that you put into patients can have long-lasting effects. In terms of diabetes control, there's looking at consensus data, hemoglobin A1C of greater than anywhere from 6 to 7 confers a risk of postoperative wound complications, and it's recommended to avoid elective surgery on patients with an A1C greater than 8. And again, as mentioned before, our target is less than 7.2%. Due to the near equivalent risk of SSO if you're below that target relative to non-diabetic patients. So I mentioned wanting to talk about penicillin allergy here. This is something that's important across general surgery and really other surgical specialties, but has a key role in abdominal wall reconstruction when we're placing a prosthetic. So 11% of patients, this is all comers, report a penicillin allergy of some kind, but only about 1 to 10% of those have a real IgE-mediated reaction, with even fewer, half to 2% of those having cross-reactivity to first or second generation cephalosporins, and even less cross-reactivity to third and fourth generation cephalosporins. Importantly, clindamycin, vancomycin, which are often alternative antibiotic regimens, are associated with C. diff and increased rates of subsequent MRSA and VRE infections, and non-cephalosporin prophylaxis is associated with more surgical site infections across surgical disciplines. So Schlosser and others examined this in nearly 1,200 complex ventral hernia repair patients between 2007 and 2018, and found that a high rate of ventral hernia patients, 26%, reported a penicillin allergy. And this was associated with comorbidities and a couple of factors for more complex ventral hernia repairs, in particular, the number of prior repairs and the presence of either mesh infection or mesh fistula, not surprisingly. Only 20% in that cohort were getting beta-lactam prophylaxis if they reported a penicillin allergy, and especially in the cases that had CDC class 2 through 4 wounds, beta-lactam prophylaxis was associated with improved outcomes. So Dr. Holland described in a study published in Surgery in 2024 an implementation of a new penicillin allergy protocol for ventral hernia repair patients that's since been expanded beyond the ventral hernia population. This was a collaborative effort with infectious disease to risk stratify patients into a low, moderate, or high risk of penicillin allergy. Generally, and I'll leave the specifics out, but in general, patients with either a rash or a remote allergy were in the low to moderate groups. Only really those who had a recent, within the last 5 years, severe reaction were classified as a high risk cross-reactivity. This was implemented into preoperative nursing, and after implementation in patients who reported a penicillin allergy, the rates of beta-lactam prophylaxis administration increased from 22% to 83% without any new antibiotic-induced reactions. Here's that protocol, and I'll include this in my slides, but briefly, as I mentioned, the kind of tiers of low, moderate, and high risk for penicillin allergy cross-reactivity. So I'll pause there, and if we want to take a few moments for discussion before I go into the next portion, I'm happy to do that, Doug.
Wonderful. Well, I love that we have a little built-in discussion section here. I do also want to highlight that we have a very special guest who is here, Dr. Kent Kircher, out of the Carolinas. He is, a surgeon that doesn't really need an introduction, but has been instrumental in much of the work that's being presented here. And does wonderful work with all of the surgeons at the Carolinas. I would love to have some of his perspective in regards to some of the controversies that have come up with regard to the concepts of pre-op optimization. One of the great questions in the chat box from Tiffany Bettigliola, I probably didn't say the last name perfectly, is about whether or not the data is in patients who are having open procedures or MIS, and do you think it matters? Dr. Kircher, what are your thoughts there?
Well, thanks for the kind words and introduction. Yeah, I think we all agree. There's no doubt that the lower the BMI, the better, right? And I'm not sure that there's an absolute cutoff. I would say in my personal algorithm, if they've got a BMI over 40, it's really unlikely that they're going to get an operation electively by me. So 40 is really probably my cutoff. And I would say to answer that question, that's true for lap robotic or open. I would say that there may be some patients that I might do laparoscopically or robotically at a higher BMI, maybe with other comorbidities, maybe even a smoker that just simply can't quit smoking, that's presented with multiple episodes of incarceration of small bowel, let's say in a small defect. I might operate on that patient and do an IPOM just to keep them from showing up in the emergency department with an incarcerated hernia and a bowel obstruction. So I think that really gets to the next point in question. How many of these patients that we are trying to preoperatively optimize for surgery are going to end up becoming an acute surgical emergency? And I would say that uh, our experience here is that it's probably more common than we would like to think. And I would say in patients that are minimally symptomatic, particularly with a recurrent hernia, and are motivated and perhaps have a primary care physician who's got them on a GLP-1 receptor agonist, then I'm more likely to push them to lose weight so that we can optimize those patients. The patient that has small bowel, intermittently chronically incarcerated in a defect and is very symptomatic and is unlikely to achieve sustainable weight loss in a fairly quick fashion, I think those patients were probably better off biting the bullet and going ahead and operating to minimize the chances they end up as an acute emergency.
Great, great insights. We actually looked at that exact question here at OHSU. What is our success rate with optimization, and what happens to patients in that process of trying to achieve optimization? Specifically with regard to weight loss, diabetes control, and smoking cessation. Across the board, with the physician-directed optimization program, we found that we were able to achieve improvements in like the big three metrics in about two-thirds of patients. Did everyone achieve the absolute numbers that we oftentimes quote? Not necessarily, but people had a positive trajectory towards better. When we looked at the patients that didn't optimize, the predictors of not optimizing or definitely getting closer were like extreme BMIs, 55 or greater, and patients who had like really significant smoking history. Um, that said, the rates of complications for patients that were unable to optimize was actually quite low. 1.5% of patients who were enrolled in our physician optimization program with quarterly check-ins with our team had unforeseen or unintended operations. They were usually performed within our health system, but some of them had them performed in other systems. So I think it answers at least the question for us, is it safe to optimize? I think the answer is yes, and it's in our best interest to get patients as healthy as possible before these big interventions. Um, just some other insights and thoughts I wanted to share. A lot of people talk about smoking cessation and how we test for it. I saw that you mentioned y'all use cotinine, and I think that's a tried and true strategy. I personally am a fan of nicotine replacement as a strategy for smoking cessation for my patients, and I think nicotine inherently isn't as dangerous. There's a lot of emerging data on that. And for those of you that are interested in nicotine replacement therapy for your patients, an option is to do nicotine and metabolite testing specifically with anabasin, which can help distinguish between nicotine replacement and someone that's smoking. And I think that's a strategy that I've implemented, especially for patients that have like needs for nicotine replacement. A lot of other good questions in the chat box that we're going to try to get to throughout the presentation, but in the interest of time, I want to make sure that Dr. Ewing has the opportunity to get through more of his great presentation. So now, why don't we get back to the presentation, Dr. Ewing?
Sure thing. So our patient came back to see us for interval reevaluation at 9 months. And this particular gentleman really sticks out to me, kind of in my memory from this fall, because he had massive weight loss. He had really worked diligently with a walking program, ketogenic diet, and semaglutide to get his BMI down to 37, 267 pounds. His A1C control was excellent. And so he was scheduled for Botox injections to his lateral abdominal wall a month prior to his repair. And so I wanted to spend a little bit of time to talk about those. Botox preoperatively to the lateral abdominal wall is essentially an opportunity for chemical component separation. As we all know, failure to achieve fascial closure significantly increases our risk of surgical site occurrences and risk of recurrence. And component separation techniques, while they can enable fascial closure, they're not without risk of and so anything we can do to mitigate that bears investigating. So Botox, botulinum toxins, there are multiple different types. These toxins inhibit presynaptic nerve terminals, blocking acetylcholine release, and they cause denervation within 2 days that peaks between 2 to 6 weeks and wears off in about 3 to 6 months. Ibarra Hurtado were the first to describe this in the application of abdominal wall reconstruction with a prospective series of 12 trauma patients who had bridging mesh. That was a paper in 2009. And he described a mean transverse defect size decrease of 5.25 centimeters and 100% of patients achieving primary fascial closure. Subsequent studies, there have been several that have investigated this from a radiologic perspective and have shown that the lateral abdominal wall musculature increases by anywhere from 2.5 to 4 centimeters. That hernia width can decrease up to 8.4 centimeters. The thickness of the obliques decreases by anywhere from about 0.5 centimeter to 1 centimeter. And then the results end up being similar whether or not the transversus abdominis is injected or just the internal obliques are injected. Unfortunately, there are no major side effects with this. There will be pain at the injection site, some superficial bruising. Patients may have bloating, which typically gets better with a binder. I'll put this slide up just to describe the variability in the Botox injection techniques. And then I'll describe the radiologists at our institution's practice. They are usually able to perform these injections with use of a short-acting anxiolytic and opiate pain medicine with 200 units of Botox separated into 12 different aliquots. And as you can see here on this top image, the injections are done equidistant at 3 points between the costal margin and the iliac crest along the mid-axillary line on each side. And they're injecting in both the internal and the external obliques, as you can see here on this ultrasound image. CT fluoroscopy is an adjunct that can be used if ultrasound is difficult given the patient's body habitus. And we typically target 4 weeks preoperatively for this. So in order to examine this, Martirano and others published a study based on the data at Carolinas Medical Center in 2022, comparing outcomes between patients who undergo component separation alone and then those who undergo Botox injection but did not get component separation. So this was a prospective single center database that was queried for between 2016 and 2021, and 3-to-1 propensity matching was performed based on BMI, defect size, hernia volume assessed by CT volumetrics, and then other risk factors for wound complications, including diabetes and wound class, CDC wound class. This study compared 35 patients who got Botox versus 105 patients who got component separations. There were similar rates of other factors of operative complexity, particularly operative time and paniculectomy. And then among the component separation group, I think it's important to note that about 45% of those patients actually had an external oblique release, with the remainder having a posterior component separation release. There were fewer surgical site occurrences at 11.4% relative to 32% in the Botox group. Botox was independently associated with lower rates of SSO in this group, and there were similar rates of hernia recurrence in the group. And so I think between the two groups. And so I think this data essentially supports Botox in complex hernia patients as a safe method that can enable fascial closure and achieve similar results to component separation and possibly decrease surgical site occurrences. All right. So I'll take us now to the operating room with this same patient and go over kind of broadly their operative course. We ended up accessing this patient's abdomen with a transverse incision, so a paniculectomy, not as low as a plastic style paniculectomy and not a T incision or a fleur-de-lis incision, but an upper transverse ellipse paniculectomy. We elevated the skin and subcutaneous tissues off the hernia sac and expose the fascial edges, and then begin by doing the preperitoneal dissection. So enter the preperitoneal space, in this case, cephalad, started by taking down the falciform ligament at that portion of the abdominal wall where the peritoneum is thick. Developed that dissection out widely, laterally. There was actually a portion of this patient's peritoneum that's commonly quite thin, where we transitioned into the posterior lamella of the transversalis fascia, developed that dissection down inferiorly from the space of Bogris and then medially into the space of Retzius, into the pelvis, all the way down to the pubis. Once this space for wide mesh overlap was developed, the peritoneum was closed with running suture, and a large piece of macroporous polypropylene mesh was placed and fixed in 4 points with transfascial sutures. We placed tap box with liposomal bupivacaine, and then placed both a subcutaneous and subfascial drain, and did our skin closure. So I wanted to present this patient's operative course as kind of a blueprint for a couple different aspects. The first of those is paniculectomy in ventral hernia repair. So obese patients are at risk of hernia, and even after pre-optimization, they often present with a paniculus. So the question arises, do we address the pannus at the same time of abdominal wall reconstruction? There are risks of doing this, theoretical risk of skin dehiscence, fast necrosis, and wound complications with a more extensive dissection. But there are also potential advantages of a paniculectomy. So there's good exposure to the abdominal wall. There's decreased weight of subcutaneous tissues that may put strain on the repair. You remove a broad devascularized scar or thin skin that may have impaired healing after surgery. This also enables improved hygiene with low rates of dermatitis and chronic infection, can enable improved cosmesis, and it also consolidates interventions for this patient, which is not without its benefits. Another anesthetic, another hospitalization exposes patients to VTE risk as well as hospital-acquired infection risk. So what does the data tell us? I looked at this study published by Dr. Elhanj and others based on the Carolinas data that evaluated outcomes in terms of quality of life, but also complications in abdominal wall reconstruction with concomitant paniculectomy. So this was a retrospective review between 2007 and 2018 that looked at patients with a large pannus undergoing abdominal wall reconstruction. All patients were offered a paniculectomy, and those who did and didn't get a paniculectomy were propensity match based on age, defect area, the subcutaneous fat volume, and other factors as you see listed there. So 34% of nearly 1,200 patients underwent paniculectomy. The paniculectomy group did tend to have a higher BMI and more females, and they were actually more likely to have a component separation. And they did have an overall increased wound recurrence rate, 45% relative to 32%. But this was really only differentiated by a high rate of wound breakdown and no difference in rates of wound infections requiring antibiotics or rates of intervention other than wound care. At the longer-term follow-up, 28 months, the rates of recurrence were similar between these groups, and quality of life based on the Carolina Comfort Scale was the same between these two groups. And so this data, in our mind, supports the safety of doing a paniculectomy in in the right setting at the same time as abdominal wall reconstruction. One of the adjuncts to this that has become a standard part of our practice is negative pressure wound therapy. And so given the significant cost of surgical site occurrences, rehospitalization, and increased risk of hernia recurrence, negative pressure wound therapy has proven beneficial in other disciplines of general surgery and has the theoretical benefit of decreasing interstitial fluid accumulation, promoting angiogenesis, and decreasing lateral wall stress. This was investigated in a prospective randomized control trial that was published in 2021 that looked at 146 patients undergoing elective incisional hernia repair of greater than 4 centimeters in transverse defect size, and found that SSOs and SSIs were less in the intervention group. This also panned out in Dr. Yuso's analysis of some of our data, particularly looking at patients who got a paniculectomy along with their ventral hernia, and found that before and after implementation of routine negative pressure wound therapy, patients had lower rates of wound complications, including rates of superficial wound breakdown. So if I'll go ahead and pause there. I know that was kind of 3 topics: Botox, paniculectomy, and negative pressure wound therapy there at once, but I'll open it up for kind of a pause for discussion here.
Great. Wonderful presentation thus far. I love all of the adjuncts that you're talking about to improve outcomes. In your experience, having now worked with the team at Carolinas now for over 6 months, tell me a little about your thoughts on paniculectomy. Did it strike you as like surprising the impact paniculectomy can have to wound healing? Because traditionally surgeons are thinking, wow, paniculectomy, I'm going to be adding morbidity, but you're demonstrating that a strategic paniculectomy can actually reduce complication profile. Tell me a little about that.
I think that I think there are a few things that I've observed, and really I appreciate all that I've learned about the management of kind of subcutaneous tissue is an important part of care of the hernia patients. I think that oftentimes patients who've have a large hernia sac, they have skin that's really attenuated and probably not very well vascularized. It's very thin, and it may not heal well. And so I think in these patients who, particularly in those patients with large pannus of thin skin that you're worried about may not healing well, an incision that excises that back to healthy, well-vascularized skin can really be beneficial. I will say that just anecdotally, patients do really well with this and are really happy, both from a cosmetic standpoint, but also from kind of restoring the contour of their abdominal wall from a functional standpoint. And so I think it's an important thing to consider. And there are some increased risk of this as the study, kind of demonstrated. So I think it may not be the right thing for every patient, but I think in the correct patient, it's a really helpful adjunct.
Wonderful. Dr. Kircher, there's some questions about drain strategies. What are your drain strategies, and how do you utilize drains in the setting of abdominal wall reconstruction?
Yeah, thanks. I just typed into the chat. So we typically still place drains in all these patients, usually one in the deep space. I would say 95% of the cases that we're doing, the mesh is in the pre-peritoneal space. So we have one deep drain that is a 19 fluted blade drain that goes on top of the mesh in the pre-peritoneal space, and then 1 or 2 subcutaneous drains that are in the sub-Q space. The deep drain comes out before the patient leaves the hospital. I think we've probably all had the scenario where the patient doesn't realize they're supposed to come back for their drain to be removed. They show up 2 or 3 weeks later, they've got a red drain site, and now you got an infection on top of the mesh. So our policy is the deep drain comes out before they walk out of the hospital. We also color code our drains so that the deep drain, the subfascial drain, has a blue stitch, a proline stitch, easy to remember, deep blue C. And everyone knows, all the nurses and all the teams know that blue stitch comes out before the patient leaves the hospital. Sub-Q drains get a nylon stitch, so the black stitch is sub-Q. I think it's also helpful in that if you have something coming out of a drain, you have a bleeding or what have you, you know what space you're dealing with. So that's helpful post-op. And then sub-Q drain comes out once less than about 20 or 30 ml for 24 hours.
Great. It's amazing that we're across the country, but we have so many similar strategies. I love it. It's the pedigree of hernia, of course. With regard to some other strategies to consider, I do a lot of robotics and I'm discharging patients pretty quickly after big recons. And for those patients that go home, basically that initial drainage from the retromuscular or preperitoneal space can be sanguinous. I try to get that out. Once it's more on the serosanguinous side, I feel more comfortable that there's good absorptive capacity, so get those out pretty early. For those patients that are leaving the hospital in an expedited manner within 1 or 2 days, we have a program where we actually have a patient performed at-home drain removal program where we get those drains out within a week for the retromuscular and then a very similar strategy for sub-Q drain removal. Especially for like patients traveling big distances to the medical centers, drains can be a pretty significant thing. We also have like a active system in place to make sure that all patients that leave with drains are tracked and contacted every 3 or 4 days with our EMR and or phone calls. But yeah, I think it's really important to recognize the importance. Does anyone use antibiotics prophylactically or empirically in the setting of drains overlying mesh? Dr. Kircher?
No, we do not. Um, I don't think the data supports it. We had a plastic surgeon that was with us for many years, and he did all of our paniculectomies for these big reconstructions, and he kept those patients on antibiotics, but he's been gone for a while, and we don't do that anymore.
Yeah, some of the older literature will highlight maybe using empiric doxycycline. I think that was much more in the setting of onlay meshes that weren't as easy to salvage if there was an infection. Even that data wasn't that strong, but I think most of us favor not doing empiric antibiotics.
Yeah, I want to jump in one thing before we move on, the Botox discussion. Botox has been a game changer in terms of getting some of these big people back together. And he alluded to this data, and he may talk about it, but I think we all know that getting the fascia back together decreases in mesh infection rates, it decreases hernia recurrence rates, and it's just incredibly important. So anything that we can do to get the fascia back together, I think is critical. If we can do that with chemical component separation and not actually having to cut fascia in the form of a component separation, I think we're helping our patients. The rub is, and if anyone in this meeting has advice for us, or the rest of us, the rub is trying to get insurance companies to pay for it. And I have found it has become nearly impossible with many insurance companies to get them to pay for preoperative Botox. And of course, we go through our algorithm. We send all the papers that we've published and other folks have published. We have a form letter that we send that usually gets denied. And then we end up on a peer-to-peer with a family practice doctor who hasn't been in an operating room in 30 years and has never seen an abdominal wall reconstruction, who tells us that Botox is experimental and that their insurance companies don't pay for experimental procedures. Has anyone had uh, better success recently? It seems like it's gotten worse.
It's definitely trending in the wrong direction, in spite of the data trending in the right direction. It's kind of unfortunate. Now, I'm in a really unique environment, Oregon, where our Medicaid actually no longer covers or supports ventral hernias, period. They don't even, it's an outright denial, and there's no option for even a peer-to-peer. It is a scary time. There's a high burden of disease, and so I think it's really incumbent on all of us as surgeons to maintain advocacy and be very involved in these opportunities to help guide the future of healthcare delivery to our patients. It disproportionately impacts patients with lower socioeconomic status. And so we really have to be advocates as well as good technical surgeons. And so that's a great point, Dr. Kircher. Anyone having success with Botox? Because if it's not happening at the Carolinas, I don't know if other people are having much success. I don't see it in the chat box. Maybe someone will give us some insights in the chat. We're doing good on time. I think let's keep going, and we have one more section to discuss, and then we'll probably have a little more time for further discussion. Dr. Ewing?
Sounds great. Yeah, sounds great. So to wrap up kind of the intraoperative decisions, I really wanted to talk about, and Dr. Kircher alluded to this, but some of our data is borne out as being really important is the preperitoneal mesh placement. So Reeves and Stopa historically established a benefit of a retrofascial mesh position, and multiple meta-analyses have demonstrated from multiple studies the superiority of sublay mesh relative to onlay and inlay mesh. But we feel that preperitoneal mesh placement has a couple of distinct advantages relative to retromuscular plane. It's a bloodless dissection plane that's not limited by the rectus sheath or requires any fascial disruption, but it's completely excluded from the bowel. So it allows for a wide mesh overlay that can extend down into the space of retzius and up to the xiphoid without violating any of those other fascial planes. And so the technique of this preperitoneal discussion, as I discussed kind of with our patient presentation, is to enter that preperitoneal plane. The real two easiest places to do that are in the lower midline, down towards the space of retzius, or superiorly. And then you can, there are a number of ways to carry that blunt dissection out laterally, often peeling the peritoneum back towards the abdominal wall. And then you can either use bovie dissection or blunt dissection with a peanut or a sponge stick to really get that peritoneum off the abdominal wall to create a wide space that extends out towards the diaphragm and such. So I just wanted to take a moment to mention that, and I'll present some data on that here in a couple slides. So I think we talked about Botox, and Botox is awesome when it can help avoid a component separation or allow someone's abdominal wall to be closed in conjunction with a component separation when they have a huge defect or massive loss of domain. But what is our approach when Botox isn't enough? The term component separation was coined by Ramirez when he described anterior component separation with an external oblique and posterior rectus sheath release back in 1990. And then posterior component separation comprises incision of the posterior rectus sheath, so posterior rectus sheath release, which may also include or extend out to a transversus abdominis release. So our approach in general to this is when we're getting ready to close, to assess the ability to close the linea alba by applying gentle tension with Coker clamps. If we're unable to reapproximate, the first step in getting more length is to incise the posterior rectus sheath either unilaterally or bilaterally. And oftentimes this in and of itself will get pretty good release to help the fascia come together. Beyond this, if the fascia still is pretty close, but maybe not quite there, that posterior sheath release can be expanded to a transversus abdominis release, either unilaterally or bilaterally, or if there's more to go, and especially if there's significant loss of domain, then an external oblique release can be performed. Now, I think one thing that is probably on everyone's mind is the risk of wound complications with the exposure of the abdominal wall, the large subcutaneous flaps that are raised with anterior component separation. I'll get to that in just a moment. But I think it's interesting to look at, okay, how much release are we actually getting from different types of component separation? And so I looked at these two cadaveric studies of comparing different component separation techniques. The first one, published in 2018 by Lowe and others, demonstrated that an anterior component separation achieved an average of 35 millimeters, of advancement, whereas a transverse abdominis release achieved on average 24 millimeters of advancement. Interestingly, though, Moores and others in 2019 compared an external oblique release, which gave 3.3 centimeters of release, to just a posterior rectus sheath release, which enabled, in their study, almost 4 centimeters of release. And the additional benefit from a TAR, adding that to a posterior sheath release, was relatively marginal. And so I think this highlights the fact that incising the posterior rectus sheath gives you a lot of good release, and that if you need a lot more length after having done that bilaterally, an anterior component separation is an important skill set to have. How can we do that with minimizing wound complications? There are multiple different techniques towards perforator sparing anterior component separation. So as I mentioned, traditionally, anterior component separation involves large subQ flacs, which put patients at risk of wound complications at very high rates. There are periumbilical perforators that are located about 2 centimeters above and down to 5 centimeters below the umbilicus. And if you preserve a wedge of subcutaneous fat in this perforator zone as you do your external oblique release, these wound complications can be mitigated. Continue that subcutaneous dissection laterally, both superiorly and inferior to that zone, and then incise the external oblique aponeurosis 2 centimeters lateral to the rectus sheath along the length of the defect. And a useful tool for this is a Yonkauer suction tip that can be passed through that incision and help you kind of tunnel behind that perforator zone where you're preserving those perforators. So what does the data say about perforator sparing anterior component separation relative to a posterior component separation release, posterior component separation, or a TAR? This was a retrospective analysis of data from Carolinas Medical Center of adults undergoing a TAR or a posterior perforator sparing anterior component separation technique. And so there was a group of 39 patients who underwent the anterior component separation versus 133 patients who got the full TAR. And the posterior component or the anterior component separation group actually had a larger hernia defect size, not surprisingly, and they were more likely to undergo preoperative Botox injections. But overall, the wound complications were similar between groups. And so I think this supports that with the perforations sparing technique, it is safe, it is reasonable to use this technique to get fascial reapproximation, which, as Dr. Kirch mentioned, is essential for lowering the risk of recurrence, mesh infection, and other surgical site occurrences. I'll pause there for a moment for discussion, and then maybe come back to this next study, and we'll kind of go from there.
Dr. Ewing, do you have only like one more slide to go after this and we're done, or do you have more?
We can do whatever is best for the group. There was this one study I wanted to share that talks about, and I can go ahead and give an overview of this now. So this is
go ahead and do it. I think it's a really nice study, and I think it would give us a good opportunity to talk about some of the various techniques.
Absolutely. So I want to talk about this one more study as it applies to preperitoneal repair and really kind of the cumulative effects that the group at Carolinas is really cyclically improved over the years. And so this was a cumulative study of 1,800 patients, retrospective review of 1,800 patients from 2004 to 2021 who underwent open preperitoneal ventral hernia repair. And the study examined an early group relative to a recent group in order to examine the effects of really cumulative process improvement changes based on evidence. And so this table 1, I think, is really awesome to look at and see how sequentially throughout the years. In 2006, smoking cessation greater than 4 weeks prior to surgery. No deep subfascial drains on discharge in 2010. Full mesh excision of mesh infections in 2011. And really sequentially, the almost yearly evidence-based process improvements that go into the way the group at Carolinas does ventral hernia repair comparing a group of patients from an early cohort versus a recent cohort and seeing kind of, all right, what's the effect of not just one of these changes, but the overall kind of process improvement. So between the early group and the late group, the more recent patients were older with lower BMI. They had more comorbidities, a higher number of failed repairs, and larger defects. So on average, patients are more complex over time. Hernia recurrence actually decreased over this time period, as did wound complications. And recurrence was strongly associated with wound complications and prior repairs. You can see here the comparison between the early and the recent groups. And then I think that it's important to look at the multivariable analysis of this data. And I've included here only the portion of the table from the recent group. But really that the most important thing that contributes to recurrence in the multivariable regression was wound complication. And so that's why so many of these interventions are aimed at reducing wound complication. And then in terms of things that reduce wound complications, key factors were operative time, paniculectomy, anterior component separation. All those did put patients at higher risk of wound complications, as well as, not surprisingly, contaminated wound class. And so I think that study for me is just really was a powerful demonstration of what cyclical process improvement can lead to.
Yeah, that was beautiful. That last slide really highlights the importance of surveillance. There was a question early in the session about whether or not how and whether or not patients should be followed after these interventions. Your program does a wonderful job of doing that. Dr. Kircher, could you talk a little about your surveillance strategy in patients who undergo hernia surgery?
For our ab wall reconstruction, we typically see these patients pretty early on, oftentimes for drain removal. We'll then see them a couple of weeks after that, and then usually a 6-week post-op visit. So those are kind of our standard benchmarks in terms of follow-up. As you alluded to earlier, a lot of patients, because we're a tertiary care center, come from many miles away and sometimes many states away. So it's not practical to have them come back to see us. Based with our research, we send out a lot of surveys to patients, and so we're able to obtain some of that data in terms of follow-up via survey, but I have to admit that it's tougher to justify bringing patients back from many hours away when they're doing well.
Great. Yeah, we've actually developed a surveillance strategy very much centered around virtual care. And so all of our patients who have repairs, whether it's inguinal or ventral, are set up with virtual appointments. We've recruited a physician assistant that runs our pre-op optimization and our surveillance programs and has weekly surveillance clinics and basically will check in with patients at variable time points depending on the type of operation and make sure they're doing well. And at 1 year, 35% of patients with these virtual encounters will identify something that we could further enhance in their post-operative recovery. Is it like a recurrence every time? Of course not. Fortunately, we're doing well there, but it's other things, they're still having core dysfunction, they're still having abdominal pain, they need a referral to physical therapy, or they need some reassurance and they're able to gain that. So I think surveillance is great. We established a precedent to do this by actually surveying patients who presented to our clinics with recurrences. And we surveyed 200 consecutive patients who were coming in with a diagnosis of recurrent ventral hernia. 90% had never told the index surgeon, and the index surgeon was unaware. And so it's really imperative to follow up with our patients as much as we can, as much as our resources will allow and permit, to really know what our true outcome is, and hopefully have eventually a database kind of like they do in Europe, where we can really have a better sense of what our true outcomes are. A lot's been talked about the past. Dr. Ewing, you made this beautiful presentation. where do you see the field going over the next 3 to 5 years? Like, where do we need to go to make abdominal wall surgery even better?
Uh, that's a great question, and I think that one that we're all kind of tasked with thinking about. I think one area is ensuring, and this has kind of been touched on a little bit. You kind of touched on this a little bit already, but is figuring out what we can do to make abdominal wall reconstruction accessible to patients. There are a lot of barriers in terms of getting to surgeons with abdominal wall reconstruction experience. There are barriers in terms of patients having the opportunity to have the support to get pre-optimized prior to an elective repair. And there's, I think, sometimes a knowledge gap amongst even primary care providers of what can be done for patients with large abdominal wall defects. And so I think that access to care and I guess kind of distribution of what we know in terms of abdominal wall reconstruction is important. I think that investigating, continuing to understand, biomaterials and the role of different mesh types is important. And minimally invasive approaches and what role they have in abdominal wall reconstruction for which patients are they best suited. I think all these are topics of investigation that are important. Yeah.
Wonderful. Dr. Kircher, any thoughts in terms of what the future holds, especially with regard to some of the things Dr. Ewing mentioned?
Yeah, I think those are all very good points. I would say as a faculty member who is an RVU based production surgeon, I think that we could use some advocacy at the national level in terms of billing and coding so that there's more uniformity among institutions and for surgeons. Abdominal wall reconstruction, core health is much more complex than it was when I came through as a resident, when we just kind of patched holes. And I do think that we've got 60 some people on this call that are here because this is an area of that demands expertise. It demands attention to detail. It demands preoperative care, postoperative care, that I think also should be reimbursed. And so I think that we could do a better job. I think the American Hernia Society is helping with that. But we as ab wall reconstruction surgeons need to get together and figure out how to make sure that we're actually being compensated for what we're doing.
Great. For those of you on the call, I think one of the things that this presentation highlights and these closing remarks highlight is the importance of specialization. And that is actually on the very much the forefront of hernia care. The Fellowship Council is now designating sites as abdominal wall specialty sites for trainees seeking advanced training. Outside of the Fellowship Council, there's many opportunities for abdominal wall specialty training now in the United States, and it's I think only going to become more and more important because the field is really evolving quickly. And for those of you that are enthusiastic hernia surgeons, again, being involved in some of the societies to build up advocacy and assure that the future is bright is really important. So um, I think we've reached our 1 hour time period. Hernia surgeons could talk about this stuff for hours on end. I want to thank Dr. Ewing for that wonderful presentation, Dr. Benzie for the invitation, and Dr. Kircher for his experience and perspective. We'll review a lot of the questions that have been posed and try to address them offline. I'll stick around for a few minutes on my own if people want to ask questions, and I really want to wish you all a wonderful evening. Thank you.
Perfect. Thank you so much, Dr. Napoleon, for being our moderator. I really appreciate it, especially when you're not in your home state right now. You're on a different coast. And thank you so much, everyone, for joining us. This is a really great turnout and a very great talk. So, Dr. Ewing, thank you so much for putting everything together. Dr. Kircher, I think you have a great fellow on your hands. I have to say he's very responsible and proactive. Everyone wouldn't mind just putting on your camera for a second so I can take our Twitter picture. That would be great.